and so my slides are visible.
Yes, sir.
Okay, so this is list. And as I tell all the time, that when we will be having the live class, try to focus it nicely, try to understand it nicely, and try to memorize the things what we'll be discussing. So we are talking about the wrist. So what are the things which is forming it? So first we are talking about the bony components. So this is the radius and ulna. This is your distal radioulnar joint. And then we are having the carpal bones. So you all know the carpal bone mnemonics. So there are two your rows of the carpal bones. The proximal one will start with from the radial side, scaphoid, and you know the mnemonics. C looks too pretty, try to catch her. So C is scaphoid. This is the first one on the radial side. Then is lunate, and lunate to remember, lunate is the when we'll be taking the probe from like this, and we'll be sliding the probe this way. The first bone what will be appearing is your lunate, and lunate is superficial. Both when we will be seeing is in the palmar side as well as the dorsal side, we'll be seeing this is the most prominent part of the bone. And then C looks is lunate, 2 is triquetral, and pisiform is sitting over here. So C looks pretty. This is the first the row of the carpal bones. Then the second row, try to catch her. Try is trapezium, 2 is trapezoid, try to catch is capitate, and H is hamate. So now here, just try to remember the shape and which part is occupied by which bone. This is also very important. You must be having a 3D anatomy in your brain. So what I tell normally, look, remember, you can remember like this. So this is like an inverted C. See, this is like a inverted C or an inverted U. This is the proximal row of the bone. So on this side, we are having the scaphoid. Here is your lunate. Here is your triquetrum and pisiform together. So the other 3 bones on the proximal row. And the distal row is like an inverted T. Inverted T. So what is there? So the 2 bone there, trapezium, trapezoid. Then in the middle part is a very big, the largest one. And the carpal bone is the capitate. And here is your hamate. Hamate is like this. So this part is your hook of the hamate. And this is the other part of the hamate. So this is your like a inverted T. So this is how we can remember the shape of these different carpal bones. And if you are having the MRI, so MRI also you have to remember the 3 bones, 1, 2, 3, scaphoid, lunate, triquetrum, and pisiform is over there. Then trapezium, trapezoid, capitate, hamate, and hook of the hamate will be here. And other things to remember when we'll be talking about this, looking about this, this carpal bones, the scaphoid. If you are holding the probe like this, then what will be seeing? When you'll be seeing the first metacarpal bone, so you'll be seeing part of the scaphoid, part of the lunate, trapezium. Then when you'll be seeing at the second metacarpal bone, then again scaphoid, a larger part of the scaphoid, then trapezoid, and the second metacarpal bone. Then we'll be coming more towards the ulnar side. Then we'll be having the lunate, capitate, and the M3, third metacarpal bone. And then when will be the pins, the scaphoid is communicating with the trapezium, trapezoid, and the first and second carpal bone. Whereas lunate articulates with capitate and the third one. And the triquetrum and pisiform, they are articulating with the 4th and 5th. So this is other things to remember. This is an X-ray. Here also you can understand that this is the proximal row. Proximal row is scaphoid, lunate, triquetrum, and pisiform over it. And then trapezium, trapezoid, capitate, and hamate. So this is your distal row. And Here it is articulating with these two. Here it is articulating with putting probe like this, and here it is articulating these two bone. So first scaphoid is articulating with these two bone, first and second. Lunate and capitate is articulating with third one, and your triquetrum and the hamate is articulating with the fourth and the fifth metacarpal bone. Now, if you are having a cross sections, this is again very important. That where is the carpal tunnel? Carpal tunnel is not in this part. Carpal tunnel is between this part. One part is over the pisiform, another part is the scaphoid tubercle. So here, see, here is the proximal carpal tunnel, and here is the distal carpal tunnel. So when we are holding the probe at this position, proximal carpal tunnel, one side is the pisiform triquetrum and another side is your trapezium. So in the base, the lunate is not there. This is one of the very common mistake I have seen done by many of the fellows. As I told you, lunate is a very superficial bone, prominent. So what we have to do, we have to slide the probe like this side. As soon as lunate will be disappearing, then only the proximal carpal tunnel will be reaching there. And same way, distal carpal tunnel, one side of your bone should be over the hook of the hamate. Once you are on the hook of the hamate, and then you'll be able to see the distal carpal tunnel. We'll be showing you, demonstrating. So these are the different short carpal bone. I'm just skipping these slides. Difficult to remember at the beginning. Now, a little bit of the 3D anatomy. I'll be showing you the 3D anatomy directly over the 3D anatomy. These bones I'll already shown you. This is to remember TFCC, triangular fibrocartilaginous complex. This is a little bit of again complex to remember, but again, because you are going to be a musculoskeletal ultrasound specialist, so you have to know this, the triangular fibrocartilaginous complex and what are the components on it. So most important part is when you are holding the probe like this, you'll be able to see the extensor carpi ulnaris. This is on the dorsal side, that is the 6th dorsal compartment. When we'll be talking about the dorsal compartment, that time we'll be remembering. And the sheath, tendon sheath over the extensor carpi ulnaris, this is the most superficial component of the TFCC. Then what will come? Ulnar collateral ligament. And then there are small intrinsic muscle. Then there is a meniscus homolog. This is meniscus homolog. It's like meniscus. And then there are 3 important muscles that is from the palmar side. So one is ulno-lunate, ulno-lunate between the ulna and the lunate. The one is ulno-capitate between the ulna and capital, and ulnar and triquetral. So these are the 3 intrinsic ligaments which will be coming. And then there are dorsal radioulnar ligament and the proximal or the volar or the palmar radioulnar ligament. So these are the 2 ulnar ligament, radioulnar ligament. One is your palmar, another is your dorsal, and either side it is encircling what? This articular disc. So the articular disc is encircled by the dorsal and the palmar or the volar radioulnar ligament, and that are the other components. So what are the components of the TFCC? One is articular disc, which is bounded by the dorsal and the palmar or volar radioulnar ligament, one this side, another this side. Then your 3 intrinsic ligament, ulno-lunate, ulno-capitate, ulno-triquetral, 1, 2, 3. And then the sheath, these are the 3 layers, sheath of the extensor carpi ulnaris, then ulnar collateral ligament and meniscus homolog. So you'll be able to see all these structures in the TFCC, triangular fibrocartilaginous complex. This is one of the very common injury, particularly the sports injury. People encounter it. Though MRI is a good one to diagnose, but even ultrasound also is important to make some diagnosis. Then the extensor compartments. Extensor compartment, very important to remember, it starts from the A and L. A means abductor and longus. And again, longus, brevis, longus, brevis, longus. So these are the way to remember. And it starts with A, and then all are E. First one is A, and then everything starts with extensor, 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 extensor. So the first compartment is abductor pollicis longus, extensor pollicis brevis. Second compartment is extensor carpi radialis longus, extensor carpi radialis brevis, and they are the one side of the listed tubercle. So listed tubercle is a bony prominence over the radius and that easily palpable. That is a landmark from where you should start. One side will be compartment 2, another side will be compartment 3. And then compartment 3, the tendon is your extensor pollicis longus. Compartment 4, extensor digitorum and extensor below that, extensor indicis. Then your extensor digiti minimi and extensor carpi ulnaris. These are the 4, and we'll be able to trace each of them, and then we have to have the also look for the proximal and the distal intersection areas. So this is the MRI, where you can also have the similar kind of things. So here is your listed tubercle, this projection. So this side is your compartment 2, and then compartment 2, then these are the tendons. Then compartment 1, these are the 2 tendons. Then compartment 3. So these are starting with, again, try to remember it, when I'll be talking this, the extensor or the dorsal compartment tendons again and again. So it starts with A. So first one is abductor pollicis longus. It starts with L. Next is your extensor pollicis brevis. Then your extensor carpi radialis longus, extensor carpi radialis brevis. Then comes the listed tubercle. Then is your extensor pollicis longus. That is only single tendon in the 3rd compartment. Then here is the extensor digitorum. That is your superficial, and below that will be having the extensor indicis. Extensor indicis is the only muscle which will be having the only tendon which will be having the myotendinous junction. And this tendon goes into the indicis, and this extensor tendon, when we are tracing it, it will be going between the 2nd and the 3rd tendons. It will be going in between these 2 tendons. I'll be showing you. And then extensor digiti minimi, this is the 5th compartment, and 6th compartment is extensor carpi ulnaris. So again, recapitulate with me. First compartment, abductor pollicis longus. It starts with A and ends with L. Abductor pollicis longus. This is the first one. Then comes is your extensor pollicis brevis. After longer, it should be brevis. So abductor pollicis longus, extensor pollicis brevis. Then it should be starting with E and end with L. So extensor carpi radialis longus, extensor carpi radialis brevis. Then comes the listed tubercle. And then comes the 3rd, extensor pollicis longus. And then 4th compartment, 2 tendons. One is your superficial one, which having the 4 component. Extensor digitorum, it is going to the 2nd, 3rd, 4th, 5th. So here it is the 1st compartment, the 1st tendon of the extensor digitorum, and extensor indicis is below, which will be going here when we'll be tracing it down. Then comes is the 5th compartment, extensor digiti minimi, and the 6th one, which is your extensor carpi ulnaris. So here is the schematic diagram of the same. Proximal intersection and distal intersection syndrome. This is also again very important things to remember. So if we are tracing, this was your listed tubercle. If we are tracing the extensor carpi digitalis longus, the 2nd compartment, extensor carpi radialis longus and brevis, then what will happen? The 1st compartment tendons, they are the deep muscles. So they will be crossing over it. And that is known as the proximal intersection areas. So there might be the friction, and there might be the area where there might be the edematous area causing the pain. And distal is, if we are tracing this below, then again extensor pollicis longus, which is a deeper compartment muscle, which will be crossing over the extensor carpi radialis longus and brevis. And this is the area where the area of the distal intersection syndrome. I'm just quickly, nerves I'll be showing you, but here it is very important again. So these are the different intrinsic ligament. Intrinsic ligament is what? Which is connecting between the one carpal bone with another carpal bone, that is your intrinsic, and extrinsic, which is connecting with the other than the carpal bones. So here to remember again, if you can remember, this was the inverted U, and this was the inverted T. So this was your lunate. So lunate, at the middle, one ligament, that is your short radiolunate ligament, radius to lunate, so short radiolunate ligament. And then again, here, this side is your long radiolunate ligament. And here, there is another, that is the ulnolunate ligament. So it is like a V, you see, this is like a V. So one arm of the V is your radiolunate, that is your long radiolunate. This is your ulnolunate. And in the middle, we are having the short radiolunate. We'll be able to see these ligaments. This is the smaller V. Then again, if you are going below that, the capitate bone, there is another V. There is another V. So this V is a long V. So between the capitate and the radius, and there is a bone there in the scaphoid. So it will be radioscaphocapitate ligament. Radioscaphocapitate ligament. This is the smaller part of the V. And on this side, what will be there? Ulnocapitate ligament. So this is the another part of the V. So we'll be able to see 1, 2, 3, 4 arm of the V, one small V, one bigger V, and we'll be able to see this short radiolunate ligament. And few other ligaments, what I told you on the ulnar side, that was forming the part of the TFCC, triangular fibrocartilaginous complex. So these white colored ligaments are basically part of the triangular fibrocartilaginous complex. What are these? These are again the ulnolunate, ulnocapitate, ulnotriquetral. These three ligaments are the part of your triangular fibrocartilaginous complex, and this is obviously the ulnar collateral ligament, which is also a part. So these four are also the part of the triangular fibrocartilaginous complex. So these are the cadaveric dissection. So smaller V, and this is smaller V, and this is larger V. This is the ultrasound pictures. So this was the dorsal compartment. This was the listed tubercle. And this was the second compartment. First compartment was here, not seen. So abductor pollicis longa, extensor pollicis brevis. Then extensor carpi radialis longus, extensor carpi radialis brevis, the listed tubercle, extensor pollicis longus, then your extensor digitorum, and here is your extensor indicis. Then come extensor digiti minimi and your extensor carpi ulnaris. This was the first compartment, and base is formed by the styloid process of the radius. Second compartment will be showing all those things on one by one, and then we'll be showing that smaller intrinsic ligaments as well. And then I'm just skipping it because I'll be showing you directly over the volunteer. This is the TFCC. This picture is important. This is the ulna. This is your extensor carpi radialis, extensor carpi ulnaris, SID. So this is one part of the triangular fibrocartilaginous complex. Below that, ulnar collateral ligament. Below that, meniscal homologue. This is the meniscal homologue. These two ulnar collateral ligament, and these are not very straight. These are a little bit of carved, sag down. And then TFCC will be, the articular disc will be here, not seen very nicely because of this shadow. And this is the triquetrum. This is not a part. Then comes the proximal and the distal carpal tunnel. So as I was telling you, proximal carpal tunnel, one side is by the scaphoid, another side by the pisiform. Another side by the pisiform, and this is your flexor reticulum. So above that, flexor reticulum basically splits and which encircles the flexor carpi radialis. Flexor carpi radialis is a tendon which is outside the carpal tunnel, and here is the flexor carpi ulnaris that is also outside the. So these are the two pillars, and two as if to who are guarding it, two guards, one over the scaphoid, one over the pisiform. So they are on the either side of this carpal tunnel. And within the carpal tunnel, what are the components? Within the carpal tunnel, there are flexor digitorum superficialis, 4 tendons, and flexor digitorum the profundus, and their flexor pollicis longus. That means 9 tendons are there. Flexor digitorum profundus and superficialis, 4 tendons, and your flexor pollicis longus. And apart from that, what is there is your median nerve. So median nerve also gives the palmar cutaneous nerve, which will be there at these positions. I'll be showing you over the volunteers. So when you are sliding the probe a little bit deeper, then is the distally, we'll be able to see the distal carpal tunnel. Distal carpal tunnel hook of the hamate when it will be coming, and above that there will be pulsation of the ulnar artery, which will be getting divided after that. So this hook of the hamate, and another is a tubercle, trapezial tubercle. So this is the distal carpal tunnel. Distal carpal tunnel, remember, is more narrow. So all the contents tendons are there here as well, which is there in the proximal, but here it is much more compact, and median nerve will be seen here, and ulnar artery will be there. Ulnar nerve will be just below that, and here the division of the ulnar artery and the ulnar nerve will be there. So visual and deep branches of this. These are in the long axis, the median nerve, and this is the Guyon's canal. Guyon's canal is this is your ulnar artery, and below beside that will be the nerve. The floor will be formed by the flexor retinaculum, and here will be the flexor carpi ulnaris, and which will be just above that. So with that, I'll be going through the 3D anatomy. So 3D anatomy is visible?
Yes, sir.
Okay.
Yes, sir.
Okay. So let me remove this. These are in the hand. We'll be discussing this when we'll be discussing the hand. So this was the flexor retinaculum. And if we are looking about this flexor retinaculum, this tendon, which I was telling, the flexor carpi radialis, this is not the component of the carpal tunnel. If you can see, this is the flexor retinaculum is encircling it. So the other, these are the other tendons, the 9 tendons, including this tendon. This is the flexor pollicis longus is within the carpal tunnel. So this was the carpal tunnel. So the 9 tendons, and this was the median nerve, and this branch is a superficial, very small branch, palmar branch of the median nerve, palmar cutaneous branch of the median nerve, which is not a content, which goes superficial to that of your flexor retinaculum. And the ulnar artery, ulnar nerve, they are also not the component of the carpal tunnel. So this is the proximal side, the palmar side, and this was the dorsal side. Let me remove some of the layers. Let me remove the connective tissue layers. Okay. So here I was trying to explain, this was the superficial branch of the radial nerve, this nerve. So let me hide it. So then this was your first compartment muscles, abductor pollicis longus. This one is your abductor pollicis longus, extensor pollicis brevis. And see, these two muscles are the deeper layers. So in the extensor compartment, we are having the superficial layers and the deeper layers. And if you can remember, last day we was discussing about the elbow. That time I was telling you that what are the superficial muscles? Superficial muscles are all are taking origin of the common extensor tendons, except one, that was here that is the superficial muscle, but not taking origin, that is the extensor carpi radialis longus. So the extensor carpi radialis longus, extensor carpi radialis brevis, and then extensor digitorum, extensor digiti minimi, extensor carpi ulnaris. These are the 5 superficial muscles. Out of these 5 superficial muscles, one muscle is not taking origin of the common extensor tendon in the lateral epicondyle. What is that? Extensor carpi radialis longus, which takes origin a little bit above at the junction of the shaft and the epicondyle. All other are the superficial muscles. What are the deeper muscles? First compartment muscles are deeper muscles. That means abductor pollicis longus and extensor pollicis brevis. These two are the deeper muscles. And you see, this is the first compartment muscle, second compartment muscle to extensor carpi radialis longus and brevis. And these first compartment muscles, they are crossing over. So this is the area of the proximal intersection syndrome. And if we are following these two tendon, extensor pollicis longus, which is going to the first. So this here is your area of the distal. Apart from that, another thing I was telling you, so this was your fourth compartment tendon, the third compartment tendon. Fourth compartment tendons are 2. One is extensor digitorum, this is extensor digitorum, and below that extensor indicis. What I was telling you, extensor indicis and one of these tendon of this extensor digitorum, they are together going to supply the index finger. So this will be coming in between these tendons, which you'll be able to identify it. And another thing to remember, out of all those things, extensor indicis is the last muscle which is getting innervated by the deep branch of the radial nerve, which is also later on known as the dorsal interosseous nerve. So that was I will be able to notice it. We'll be able to see the pulsations and we'll be able to see the in the fourth compartment. Apart from that, these are all the deeper layer muscles. So what are the deeper layer muscles? One is your first compartment muscles, abductor pollicis longus, extensor pollicis brevis. These are the two deeper layer muscles. Then is your extensor pollicis longus. Then is your extensor indicis. So these four muscles are in the wrist are the deeper layer muscles, and rest all are the superficial layer muscles. Out of all those 5 superficial muscles, one is not taking origin of the common extensor tendon, that is your extensor carpi radialis longus. So with this, let me start scanning on the volunteer. Okay, series, my slides are visible.
Yes,
okay.
Sir.
You can see my volunteer's hand.
Yes, sir. Yes, sir.
So I'll start with the dorsal compartments. So here, the best to examine is your either hockey stick probe or the high frequency linear probe. So my aspect marker is towards the ulnar side. So and I was first palpating over the listed tubercle. So this bony projection here is your listed tubercle. So this was your listed tubercle. So this cleft tendinous is your extensor digital, extensor carpi radialis longus and extensor carpi radialis longus. This tendon is your extensor pollicis longus, and here is coming the fourth quadrant. So this is the starting point, or we call it as a home page. Always try to palpate that. I am palpating here. That is the listed tubercle. Most superficial bony prominent is the listed tubercle. Hold the probe there, and then go this side will be your radial side will be your second compartment and first compartment. And if we are going to the ulnar side, we'll be getting the third, fourth, fifth, sixth compartment. So that is where we should start. So again, coming to the home page. So this was your home page, listed tubercle. Sorry, my aspect. Okay, my aspect marker is towards the. So this side, left hand side of this side of the pro is your ulnar side. This side is the radial side. So this projection is your listed tubercle, third compartment, second compartment. So now what I am doing, I'm listed tubercle. I'm going laterally. Sorry, radial side. Now I can see the second compartment tendons very nicely. This was your extensor carpi radialis longus. This was your extensor carpi radialis brevis. Now what I'm doing, I am coming to the first compartment. So I'm coming to the first compartment, and here I have to put a lot of gel, otherwise I'll not be able to see it nicely. Let me put some more gel there. So what you can see here, abductor pollicis longus and extensor pollicis brevis. And below that is your radius diagnosis. And here you will be able to see that here the radial artery is pulsating. So again, start from the listed tubercle. This was your listed tubercle. And then from the listed tubercle, I am coming from the radial side. So first compartment, 2 tendons is very nicely seen. And then I am coming to and I am turning the hand. And here is, you can see the 2 tendons nicely. So now see here, you can see the pulsations of the radial artery. If I am coming here, pulsation of the radial artery. Can I appreciate? I can give color also. So this was a radial artery. And now, see, look at the first compartment tendon. This is very important because this is these two tendons are getting entrapped with this extensor reticulum. So I'm keeping it here and I'm going to distance. What is happening? Radial styloid process is disappearing. And you see radial artery also, you see, is coming below the first compartment tendons. See? Now you can see appreciate the tendon and the bone is appearing there is now so muted, please remain muted. So here the first, so here if I'm going more proximally, then the radial artery is going away and the radial styloid process. If I am coming below distally, then the bone what is starting there, the bone what is starting there is your, this is your styloid, the scaphoid, and the artery is coming crossing here below the first compartment. So if you are going for the injection, for the decoherence injection, so the area of the injection is here, where the styloid process is, not here, where the where the radial artery is coming below. This is not the area to inject. Here we can also see the same first compartment tendon, but injection to be done at this part, not here. Remember that. So now I am coming to the second compartment. Again, listed tubercle. This was the listed tubercle. This was the second compartment. Second compartment, remember, the right hand side is your extensor carpi radialis longus and extensor carpi radialis brevis. Now, if I'm going proximally, see what is happening. If I'm going proximally, see the first compartment tendon from here. See, this is the first compartment tendon. You look at these first compartment tendons. When I'm going, they are coming from this side, it is going over there. See, these are going. So this was your extensor pollicis longus and abductor pollicis brevis is coming in. This was another. So the abductor pollicis longus, extensor pollicis brevis, they are just crossing over it. This is the area for the proximal intersection. They are crossing over the second compartment tendon. Is it clear to everybody? So the tendon, the second compartment tendon, so the first compartment tendon is going over it, and that is the area of the proximal intersection. So now, if I am coming again here, so look at the third compartment tendon. So third compartment tendon is here. This is the third compartment tendon. What is that? Extensor pollicis longus. So this is the tendon is very nicely seen now. And if I am following that extensor pollicis longus, it will be going above the, you see, now it is going above the second compartment tendon. Can you appreciate that? This was the third compartment tendon. Third compartment tendon is now going above the second compartment tendon towards the thumb. Everybody can appreciate. So that is the area of the distal intersection syndrome. Or you can do the other ways. You can from here. This is the second compartment tendons, just at the middle of the screen. If I am these two second compartment tendon, if I am following it, just see something will be crossing from the left hand side to the right hand side. You see, from the left hand side to right hand side, something is crossing. What is that? That is your third compartment tendon, extensor pollicis longus. So this is the area of the distal intersection syndrome. You see, extensor pollicis longus is crossing over these two tendons. These two are the second compartment tendon. Over that, see, this is crossing. So this is your area of the distal intersection syndrome. Okay, so now third compartment we have discussed. Third compartment, this was the third compartment. And now if I'm going here, this is the fourth compartment. Fourth compartment, as I told you, there are two muscles. If you're looking about, if I'm going a little bit more proximal, you see, I'm holding the probe like this, I'm going a little bit more proximal. So what is happening? See, here, when I'm coming distally, these all are tendinous, except lower part. This part is basically my tendinous junction. The black area is the muscle, this is your tendon. That is your extensor indicis. What I told earlier, that extensor indicis become the last tendon to get. So this is your also the going to the index. This is the part of the extensor digitorum, and extensor indicis basically goes and in between the third and the second and the third tendon, and it is going there in between. See, again I am coming from proximal to distal. See what is happening? Extensor indices is keeping. So this was your extensor digital. And if I'm going distal proximally, you see that this is becoming the more muscular, and then extensor pollicis also, they are coming here. These two are deeper muscles, this and this. They will be crossing, below the, you see, this was your extensor digital. This was the extensor indices, this was the extensor pollicis. If I'm tracing it more proximally, so these two muscles, first one is your extensor indices and this is the extensor pollicis. They will be going below this extensor digital muscles and going to the radials. Sorry, ulnar side. And then the other, this was your first compartment muscle. Abductor pollicis longer, extensor pollicis brevis. They also will be coming. This was your extensor digital. Now that is no longer tendon, it is now become muscle. So this was your extensor pollicis brevis. Abductor pollicis longer, extensor pollicis brevis, right? So they are going below, they are the deeper compartment muscles. So these are your superficial compartments, extensor digital. Again, coming to the wrist. So this was your distal tubercle. This was your distal tubercle. So this was your third compartment muscle. Extensor pollicis longer. This was your fourth. But in the fourth, this part is your extensor indices, and this part was your extensor digitorum. This was your going to the extensor digitorum, which is going to the index, and this muscle is tendinous part is going in between the second and third. So now, if I'm going more towards the ulnar side, then you'll be able to see the extensor digiti minimum. So this was your extensor digiti minimum. This is your extensor digiti minimum. Whenever extensor digiti minimum, remember, lies between the radius and ulnar. This is ulnar, this is radius, the extensor digiti minimum. This is your fifth compartment. That is also a superficial muscle. And if you are going this ulnar side, here, this is your extensor carpi ulnaris. This tendon is extensor carpi ulnaris. There is a group. So in that group, the extensor carpi ulnaris. So this is your extensor carpi ulnaris. So these are the dorsal compartment. And here, as I told you, there is a possibility of the proximal intersection and the distal intersection. Okay, another thing I forgot to mention here, that posterior interface nerve, which is basically continuation of the deep branch of the radial nerve, and it supplies the, as I told you, extensor indices is the last muscular branch. Posterior interface nerve is basically the motor nerve, deep branch of the radial nerve, and that can be traced here. There is a pulsation there. Look at here. This is the extensor indices muscle, which will be supplied by the terminal branch of the. You can see the pulses there now. There is tiny pulses there. Here, that is the posterior interface nerve. I'm just tracing it more proximally. That day also I have shown you. Here. These are the extensor indices. Now, I'll be quickly showing you the superficial branch of the radial. Superficial branch of the radial nerve, that day I told you that it comes under the brachyradialis muscle, and after that it becomes in the subcutaneous plane and lies between the radius and the radial artery. So you can trace it between here. So you can see the radial artery, and this was your radial artery, this was your radius, and this is your superficial branch of the radial nerve. You can see this nerve, honeycomb-like appearance. This is your superficial branch of the radial nerve. And if you are tracing that nerve, you see it will be, that is your nerve. Just honeycomb-like appearance, very nicely seen between the radius and the radial artery. This is your nerve. And you follow the nerve just below the white arrow. So what will happen? It will be coming more superficial, and then it will be coming. You see, the nerve is now a little bit fattened, this black area, and it will be coming below the. See, this is the nerve. This is the nerve. This is the nerve. And it will be coming below the cephalic venous. I have to go check to see the pen. This is very superficial. Vein gets collapsed as soon as I am putting the probe. I have to keep it. I cannot place it. Okay, here is the vein. As soon as I am putting it, it is getting compressed. Anyway, so nerve is seen here very nicely. This was your nerve. This was your nerve, seen between the radius. If I'm going more proximally, this was your nerve, and the nerve gradually it goes more towards the bone. So this was your nerve, superficial branch of the radial nerve, and this was your nerve, and it will be coming and coming in the dorsal of the wrist, dorsal side. So now this was your dorsal aspect. Any questions, anything you wish to see? Then I'll be going into the palmar surface, carpal tunnel. Any questions? If you wish to see anything again, I can show you again. Anybody wish to see anything again? Okay, so for the palmar side, normally we should be starting. Let me increase the depth a little bit. So okay, so my aspect marker is now towards the radial side, and it is on the left side of the screen. So here, so this muscle is your pronator quadratus. This muscle, this is the radius. Let me increase the depth a little more. So this side is your radius, this is your ulna, and this muscle is your basically horizontal muscle, pronator quadratus muscle. And if I am following that pronator quadratus muscles, and if we are following this bone, this is your radius, this is the ulna, and now you see this radius and distal end of the radius is vanishing, and now one bone what is appearing is your lumate. So this is your lumate. So here it was radius, and now it is your lumate. And this side is your ulna, radius, pronator quadratus muscle. I'm coming this distally, and then what is happening? Then the lumate is come. So now at this point, if I'm going towards the radial side, the bone what will be there? This bone is your scaphoid, and this bone will be your trifid. Now at this level, this is not the carpal tunnel. If I'm going more distal, so this is the carpal tunnel. So here one bone is your pisiform bone, one bone is your scaphoid bone, and this is your flexor reticulum, pulsation of the ulnar artery. Radial artery, remember, it has gone to the other side. So here radial artery will not be seen. So this is your carpal tunnel. But again, to see the carpal tunnel, I need to flex it. Otherwise, I will not be able to flex the wrist. Otherwise, I will not be able to see the content of it. So if I am flexing the wrist, now I can see it much better. Okay. So this was your pisiform, this was your scaphoid. What is that bone? Lunate has ended. So what will be this zone? This is your capitate. This is your hamate. So the floor of the carpal tunnel is formed by capitate and hamate. Remember the capitate and hamate. So first when we were talking about the carpal bone, they were projecting. And this is your flexor reticulum, roof of the carpal tunnel. So there is one tendon here. What is that tendon? Flexor carpi radialis. There is another tendon here, that is your flexor by ulnar. So this is the radial artery. This is the Gans canal. Again, remember Gans canal is outside the carpal canal, and there is your ulnar nerve. This is the radial nerve. This is one of the tendon which is within that. That is your flexor pollicis longus. That is the content. And then you can see the different, the four tendons from the flexor digitorum superficialis and the flexor digitorum profundius. So these are the flexor digitorum superficialis and these are the flexor digitorum profundus. So these are the content of the carpal. Again, let me show you. So it should be starting from here. So the distal radioulnar joint, and then the pronator quadratus, then radius, ulna, radius on this side, ulna on this side. Now lunate bone is appearing. Lunate bone is appearing. I am going more distally. Now lunate is vanishing. And now that is the starting point of the. So you can see the two bones are appearing on the two sides, and that is the proximal carpal tunnel. And from tilting the probe, then I can see all the contents tendons of the carpal tunnel. And remember, if you are extending like this is extending, then you cannot see the content of that. You flex it, then you'll be able to see the content. Otherwise, you will not be able to see the contents. And now at this point, look at this pisiform and the ulnar artery. Follow the ulnar artery and go more distally, and another bone will come. Another bone will come. So when another bone will come, so this is the another bone, and that is the hook of the hamate. So when so just follow the ulnar artery, ulnar artery, and I'm keeping the middle of the spill, that is the ulnar artery. So this is the pisiform, and now I am following the ulnar artery. See, one bone has appeared. Can you appreciate that? One bone. So this bone, what is appearing? Look just below here. One bone will be appear here, and that is your hook of the hamate. Again, let me go back. Let me follow the ulnar artery. This was the ulnar artery in the middle of the screen. I'm keeping it, and then if I'm going distally. Okay, so this bone, what is coming here? This bone is the hook of the hamate. So at this position, I am keeping it on the one side, and again, this is your sorry. So distal carpal tunnel is little difficult to see, but if we are following this, it will be easy. So this was your proximal carpal tunnel, and you can see the ulnar artery pulsation very nicely. This was your proximal carpal tunnel. So now, if I am going, actual one, so we'll be able to see a larger area of the body, larger area of this. So now, this was your lunate, this was the ulnar artery, ulnar nerve. So now I am going distally. This was the pisiform bone, and now I am going more distally. This was the proximal carpal tunnel. More distally, just follow the ulnar artery. Follow the ulnar artery is dipping, and now one bone is coming. This is the hook of the hamate, and you keep that one side of the screen. This is I'm going to feed it. এই সঞ্জীব এদিকে একটু আইটো ফ্রিজ করবে, আমি এটা হাতটা সরাতে গেলে ফ্রিজ করতে পারছি, এটা পাশে ফ্রিজ বাটনটা টিপে আমি যখন দিচ্ছি। Okay, so follow this ulnar artery again, pisiform and the scaphoid on either side. So this was your proximal carpal tunnel. I am now following the ulnar artery, going distally. So now one bone is starting. That is your hook of the hamate. Okay. So now see here, this was the ulnar artery. This is your bone, very small piece of bone. This is the hook of the hamate. Why it is bone? Because you can't see anything here. This is your the acoustic side, and this side is your tubercle of the trapezium, and these are the other carpal bones. That means this is your little bit of trapezoid and the capitate, and here is your the distal area, as I told you. This is more horizontal. Flexor retinaculum is more horizontal. Here is the flexor retinaculum. This is the ulnar artery. This is your flexor pollicis longus, and these are the flexor digitorum superficialis and the posteriors. So here, if you are following that ulnar artery there, you'll see the ulnar artery will be gradually divided into two, superficial and the nerve will be divided into two. So here is your Goyen's canal. This one. So here is your Goyen's canal. So this was your ulnar artery, ulnar nerve, and floor is by the flexor retinaculum. You follow this ulnar artery and the nerve. This was your pisiform bone. The hook of the hamate will be appearing here, and you'll see that the ulnar artery and nerve they will be getting divided. So I was here. Follow the ulnar nerve. See the ulnar nerve is very nicely seen just at the middle of my screen, and now the ulnar artery will be getting divided. And the ulnar nerve is also getting divided. You see now the ulnar artery is divided. Hook of the hamate is appeared. Hook of the hamate is very bright, white hyperechoic area. I can compress the ulnar artery here under the already divided into two. The nerve is getting divided into superficial and deep. So this was your hook of the hamate. Hook of the hamate. If I'm sliding the probe on this side, you can also see this is the base of the hamate. So here at this position, this is a needle bottom rotating. Needle lekha se niche that needle lekha se So if I am holding it here, while the ulnar artery was seen in the distal part of the carpal tunnel, if I am going on the lateral side, then I will be able to see the whole of the hamate, including base and the hook. So this was your base and the hook hamate, and here if I am going there, so this was the ulnar artery, ulnar nerve, while it is getting divided. You can see the artery is getting divided. It was 1, and now it is getting 2, 1, 2, and also nerve you see 1 and getting 2. Superficial and deep. So this was your hook of the hamate and base of the hamate. So my marker is just at the junction of the base and the hook of the hamate. And here you can compress the ulnar artery against the hook. So I'm holding the probe little bit of oblique. So this was your hook. Hook of the hamate can be seen if I'm holding like this, but hook of the hamate is better seen. Which color? So what I was trying to explain? This was your base. This was your hook. Hook, when I was holding the probe over it, then I'm seeing only part of the hook. But when I'm tilting the probe like this, then I can see the hook and the base of the hamate like this. And here I was seeing the ulnar artery and the ulnar nerve getting divided. Okay, I forgot to show you another nerve, that is your comorcutaneous nerve of the median nerve. Just follow the median nerve. This was the median nerve. If I'm going more proximally, median nerve was dipping here. There is no. So my exactly middle is your median nerve. So now if I'm coming median nerve, see some branch is going towards the ulnar side. See. So you can see there is one nerve. This black one is going, and it is piercing that. Follow that part. It is piercing the flexor retinaculum and coming superficial, and it is coming above the flexor retinaculum. So you see, this is the median nerve. This is the median nerve, and if I am going more proximally, so the nerve is getting mixed with the median nerve. So now it is getting mixed with the median nerve. And now, if I am going more proximally, see, one nerve is going more superficial and more towards the right hand side of the screen. Everybody can appreciate that. That is the comorcutaneous branch. It is very small, tiny branch, and now it will be going. See, now it is piercing and it is going above the flexor retinaculum. So this was the median nerve, and now the divided. If I'm going towards more proximal, so now this nerve is getting mixed with that. So this was your comorcutaneous. Okay, so now I was going to show you some of the intrinsic ligament. So if I'm holding the probe here, so what was there? This was your distal part of the radius. And if I am coming here, so what is seen on this side is a bone, your scaphoid. So if I'm flexing, this is scaphoid, this is the neck, and this is the body of the scaphoid. This is the whole of the scaphoid. This is the neck. This is the commonest area of the fracture. And if I'm going medially, now the lunate is coming. So this is lunate. Lunate, the most superficial band. This was not lunate. This is lunate. This is lunate. And then this is your. This is lunate and this is your capitate. Lunate and capitate. And you can see the median nerve in the long axis. This is the median nerve in the long axis. This one. This is the median nerve in the long axis. The black one. Above this flexor tendons. This one. So, and here you can see this part of the bone is the radius, lunate, and capitate. And here, as I was showing you, that if I am holding the distal part of the over the lunate, this was lunate, and if I'm holding the probe straight, so this ligament is your short radiolunate ligament. If I'm keeping the distal part of the lunate, the probe over the lunate, this is your radius. This is your lunate. So now if I'm holding the probe over the distal part and if I'm sliding the probe more towards the edge of the radius, more toward, look at my probe, how I'm holding the probe. I'm holding the probe like this. Then this ligament is your long radiolunate ligament. This ligament, long radiolunate. So now at this position, if I am keeping the proximal part fixed and I am sliding the probe, distal part of the probe, now the capitate bone will come. Now this is your capitate, this is part of the scaphoid. So this ligament, what is coming here, is your radioscaphocapitate ligament. Radioscaphocapitate ligament. This is the longer part of the field. Okay. So these are the three ligaments from this radial side. Again, I'm showing you. If I'm holding the probe like this is your lunate. This is your radius. So this is your short radiolunate ligament. This hyperical carrier. And now what I'm holding, what I'm doing, I'm fixing this part of the probe and I'm sliding this part of the probe to the more towards the radial side. Look at my movement of this probe. So now this ligament is your long radiolunate ligament. And now what I'm doing, I am fixing the proximal part of the bone of the radius and I am sliding the distal part more laterally. And now the capitate bone will appear. So now this ligament is your this is scaphoid, radioscaphocapitate ligament. Okay. So now come to the ulnar side. Hey, here again, you hold the probe over the scaphoid and the radius. So this side, left hand side is radius. This is your lunate. The scaphoid is not here. Radius and lunate. And now I'm fixing the distal end over the lunate, and I am rotating this proximal part. So now the radius is vanishing. Now the bone what will be appearing here is your ulna. So this is your ulno-lunate ligament. This ligament is your ulno-lunate ligament. Ulna and lunate. So this is a part of the TFCC, ulno-lunate ligament. So one part of the bone is your ulna, another part, not the whole ligament is seen, little bit of area of the is your hypoechoic. As I told you, the ligaments are basically the sagging down, so it might be not the whole part is seen. And now at this position, what I'm doing, I'm fixing the ulnar side and I'm fixing and I'm rotating the distal part over the capitate. So now ulnocapitate. So now this ligament is your ulnocapitate. So one side is your ulna, another side is capitate, ulnocapitate. And now if I'm rotating the port further, ulnotricuspid. So this is the ulnotricuspid. deeper one is triangle. So now the TFCC, I'll be holding the proof like this. So TFCC, most superficial part was what? Most superficial part was your tendon sheet of the
Extensor carpi ulnaris.
carpi ulnaris. You can see that extensor carpi ulnaris tendon very nicely. So this was your extensor carpi ulnaris. Just below that is your tendon sheet of extensor carpi ulnaris, and after that, so what you can see here. Okay, so this was your most superficial. This was your tendon sheet of the extensor carpi ulnaris. Then this sagged part is the ulnar collateral ligament of the wrist. And then this is your meniscus bone. This is your lunate bone, ulnar styloid process. So this whole area is the triangular fibrocartilaginous complex. So what are the components? Most superficial one is your tendon sheath of the extensor carpi ulnaris. After that, this bright white broad area is your ulnar collateral ligament. After that, this part is your meniscus homolog, and this is your bone. And here will be coming the articular disc. I'll be showing you that in the short axis. So again, I'm showing you. So this was your extensor carpi ulnaris. Just below that, you can very clearly see the three layer structures. So this was one tendon sheath. This was your ulnar collateral ligament. This is your meniscus homolog. Part is very seen nicely. And here is your this is your triquetral bone. This is your lunate, triquetral lunate, and here is your articular disc. And again, see, if you are making a radial deviation, then you can see it better even. Okay, so now see the structures. So again, layer by layer, tendon sheath of the tendon extensor carpi ulnaris, then your ulnar collateral ligament, then is the meniscus homolog, and then the triangular fibrocartilaginous complex. And now, if I am holding the probe like this is a cross section of the extensor carpi ulnaris. Look at my probe position. I am holding it. Patient is putting the hand like this, and this tendon over exactly the center of my this thing. Center of the screen is the extensor carpi ulnaris, and the dorsal side, right hand side of the screen is the dorsal side. So now this is the ulnar styloid process. So now what I'm doing, I'm just sliding my screen probe, and my ulnar styloid process is vanished. At this position, what I'm doing, at this group, what I'm doing, I am making it. So this is your articular disc. This is your articular disc. So this is the tendon, and this is your articular disc. This is your articular disc. And here rounded one side and another side, two ligament structures. Here one, another one is here. This is the disc. This is now hyperechoic. You can make it hyperechoic. Not whole will be hyperechoic at a time. Part will be hyperechoic. And this is one ligament. This is another ligament. This is the dorsal radio-ulnar ligament. This is your ventral or the volar or the palmar radio ligament. This side is your dorsal, this side is, and this is your articular disc. Articular disc part will be hyperechoic and mostly it will be hyperechoic. So this is your triangular fibrocartilaginous complex. Okay, so thank you very much. I know you might be having some question, but as I told you, you just go through the recorded lectures, and you can ask me the question next day. Today I have to rush for the airport. I don't have the time to take the questions. I'll be answering all your questions. Here the Series and Milton is here. They can answer some questions, but again, I'll be answering all your questions, whatever you are having. Let me make Milton co-host, and let me make Series host, and I'll be running towards the airport. Thank you very much. Thank you very much for joining. And whatever the questions you'll be having, I'll be answering those questions next class. Thank you very much.
Sir, have a safe flight, sir. Have a safe flight.
Thank you. Thank you.
Okay, Milton, I can see your slide.
Okay. Good. Hello. Very good afternoon. Okay. After a very nice anatomical demonstration of the wrist, because a lot of ligaments, a lot of muscles and ligaments and tendon cross the wrist, both dorsal and palmar part. So actually, a lot of pathology in and around the wrist joint. So we have to know measure of the pathology, and another one things, this ultrasound is very much hands-on like this, because some special changes it see the a lot of ligaments, but if you are not in right position you cannot see the a lot of ligaments under the ultrasound. Okay, so today our topics, the wrist pathology. So commonly share here, like the dequervance symptoms, carpal tunnel symptoms, proximal and distal intersection symptoms, then chiralgia paresthetica, Guyon's canal symptoms, ganglion cyst and wrist arthritis also. Okay, so as already told by Gautam sir, the decorvance is the first compartment disease, especially the abductor pollicis longus and extensor pollicis brevis. These two tendons actually going within a common sheath, and when actually it is cross the wrist joint, that times actually sometimes if there is any direct trauma or sometimes the repeated work, it causes the repeated micro trauma within the tendon, around the tendon and around the sheath. So it may collection of the some fluid. Sometimes it causes the tendon degeneration, so causes the pain when actually work with this tendon, like the EPL or APB, when it actually stressing or when actually it is pressurized, when actually we use the thumb, like when we are actually writing or sometime we are gripping something, some materials by the hand, it actually causes the pressurize this compartment, so that times actually causes the pain. So here is the cadaveric actually photos. Now actually pathology, as I already told, the repeated movement of the thumb, so low grade micro trauma at the level of the radial styloid process, because already we know that we can feel very easily, because it is a very superficial, the listed tubercle. From the listed tubercle, if we are go to the radial side, that is the second and then the first compartment, and the listed tubercle, when we are going to the ulnar side, it is the third compartment. So listed tubercle is divided, second demarcation between the second and the third compartment, but decorvance is the pathology of the first compartment. So actually when we have put our ultrasound probe over the dorsal part of the radius, that time we can find the listed tubercle, then the second compartment, after that the first compartment. Okay, so it is very important that it is very localized, and actually repeated trauma is the main factor for the generation of the pain. So subsequently it is impinge, and when actually we are working with the thumb, that times actually causes this pain. So it may be the either the inflammatory or maybe the degenerative change, and histologically we found the fibrocartilaginous metaplasia, deposition of the mucopolysaccharides. Actually, these all are the microscopical founds. That's been the histological founds. It is not our main part. So, but we have to know these things. And there is the neovascularization and neoinnervation. So far, when actually the neovascularization or the inflammation, that times actually we saw that some Doppler flow under the ultrasound. So what are the risk factors? So actually, those people are working like the gardening or like the playing golf or racket sports or lifting the baby. So that time actually pressurize this area. So it's maybe sometimes the part of the form of the rheumatoid arthritis also. Why? Because when actually you know that it is a small type of the joint, when actually we consider the rheumatological disease, that time actually it affect these joints. So this tendon also cross the joint. So this inflammation also may affect the tendon sheath and causes the inflammation. Okay. So another is the direct trauma, and another is the fluid retention due to the hormonal changes during the pregnancy. So this is the examination. It's very easy. So thumb is just flexed, and after that the wrist is enclosing, and then after we pressing these things towards the downwards. Okay. So if patient feel the pain along the thumb, and it is just over the wrist joint, not distally, not proximally, because when it is proximally, that times actually we have considered either the any intersection symptoms. So it's just over the pain over the wrist joint. Okay. So another the ultrasound. So the first picture, there is the almost there is no Doppler is showing, but there is the following the sheath is thickening. Okay, the sheath is thickening. The second picture, it shows the Doppler study is very well looking Doppler study, and the third picture, that is the long axis view. So it also showing the some fluid and also the some Doppler over the tendon, and it is the joint. So sheath is like there. So if there is any inflammatory disease like the rheumatoid arthritis, and wrist is the common site for the rheumatoid arthritis pain. So if there is any pain, swelling, redness, that time actually considered also the any rheumatological disease may or may not. At the third picture, you can see the only the sheath is the thickening. So treatment, rest. Actually, those people are working in the gardening, like the racket or the golf. So there is no no sign of the inflammation. That time the rest is the very important treatment part. So eyes and sometimes inner sides and thumb. Sometimes we have fixed this area thumb. If not improve with the wall type of the conservative treatment, then we are looking for the intervention like the PRP for the degenerative changes. If there is the inflammatory changes, that times we have considered the steroid. Okay. So this is the actually you can go either by the short axis or either by the long axis. Okay. So if you are in the short axis, long axis view, that time it is considered in the considered in case of the consider of the tendon, it is the short axis, but needle is come, and you can see the whole length of the needle. So it is the in plane view. Okay. So it is the out of plane, you can go through everywhere, but not within the tendon, just outside the tendon, because it is actually if you are going for steroids, so that time you have not doing any intervention like the with the steroid within the substance of the tendon, because it causes the damage of the tendon. So if you are considering the PRP, that time you can go within the tendon. If there is multiple microtrauma, so then you can consider the PRP. But one important questions, if there is an inflammation or not. If there is the inflammation and inflammatory marker is high, like the ESR and CRP is so high, so that time you have considered the steroid first. But multiple steroid or multiple setting of steroid not very good for the tendon, because it's losses the actually tendon laxity, and it causes sometimes the tendon rupture also. Now we are looking for the carpal tunnel syndrome. This is very common, and this it is a tunnel, and this tunnel actually made by the osteofibrosis tunnel, because the floor of this tunnel is the bony part. It is mainly the carpal bones. The above part, that is actually by the retinaculum on it's retinaculum in on like of the ligament. So it is the osteofibrous. So the floor is the osseous and the roof is the fibrous. Okay, the content. There is the total 10 content. Among them, one is the nerve. That is very important nerve. That is the median nerve, and second is the 9 tendon. So this 9 tendon is actually divided into the 3 tendon sheath. Number 1, the flexor pollicis longus within the one sheath, and there is the 2 group of the muscles. One is the flexor digitorum superficialis. There is the 4 tendon in the within one sheath, and another is the flexor digitorum profundus. So 4 flexor digitorum superficialis is within the one tendon, and 4 flexor digitorum profundus, they are within the one tendon. So there is the 3 common sheath there. Okay, and another very important part, actually the superficial muscle and deep muscle all are divided, or all are sometimes there is the superficial, one is the superficial, there is the superficial digitorum superficial, and profundus there is the is the deepest part. Okay, so we can see here, um, so almost we talked about these things. So now very important part, because already we saw in demonstration like the retinaculum is attachment, because there is a 2 attachment. One is the proximal and one is the distal. So proximal attachment, it is actually the convex. Okay, and it is attached with the scaphoid tuberosity as, and the another side is the pisiform. Another part is the pisiform. So, and total length is the 3 to 4 total wide is the 3 to 4 centimeter, and the proximal part is the convex, and distal part, that is actually the flat, and it attached within the trapezium as well as the hook of the hamate. So proximal, that is the convex part, and distal part, that is actually the flat part. So this is the very important, and proximally it is attached with the scaphoid and the pisiform, and distally it is the trapezium and the hook of the hamate. So there is some same risk factor like the obesity, pregnancy, diabetics, hypothyroidism, rheumatoid arthritis, and sometimes there's the anatomical variation. So if there is any pain here, so that time actually consider if there is any risk factor, uh, so you have to actually minimize this risk factor. Like there is the obesity, so patient should be decrease the weight, and if there is the uncontrolled diabetics, so must be controlled, and always consider the hypothyroidism either present or not. Okay. If median nerve is impinged, within the carpal tunnel. Okay, so that time actually what type of the sign symptom we are get from the patients? That is actually the dull aching pain, usually in the uh, lateral side or in the radial side. Okay, so usually in the thumb as well as the middle, thumb, index, and the part of the middle. So these three finger actually the numbness, as well as this pain actually sometimes the pin like pain, and it increasing at the night. Usually night time is the more in pain. Okay, the frequency, the tingling, and the sometime when the digit is working, and long time writing, that time actually causes the heaviness, numbness of the pain. If sometimes patient told in our OPD, like when I am actually holding my phone for talking, that time actually I cannot hold for the few minutes. Within the few minutes, my hand, especially the radial side, that is the heaviness and numbness and some tingling over the area. Okay, so now the causes, almost we have already considered these things, the inflammatory or either the when actually thickening either the any tendon within the carpal tunnel, this 9 tendon, or if there is thickening of the retinaculum, it causes the compression of the median nerve. If there is the outside of the compression, that time actually we have considered it as the compressive neuropathy. But when nerve itself, the swelling, and it needs more space for travel through the tunnel, that times actually we considered itself there is the problem. Okay, so it's a diameter, there is the short axis, long axis, transverse diameter, then we have calculate there is the actually the demarcation, how much actually we have considered below the 10 millimeter squared, that is the normal, above the 10, that is actually the pathology considered as the CTS, and more than 15 millimeter squared, that is actually the severe CTS. Okay, so there is some disease, so that consider also in case of the CTS, like the either the diabetics, rheumatoid arthritis, obesity, pregnancy. Sometimes the ganglionic cyst is there, so it causes also the compress by the outside, and sometimes the gout, menopause, sometimes the amyloidosis, or um, like the psoriatic arthritis also. So clinical evaluation, there is the Finer test. Okay, there is the Finer test. It's like these. Okay, there is the Tinel sign because it is most superficial. Because in the mid arm, it is the of the middle, almost the deep part. But when it's come to the wrist, it gradually the superficial, just under the flexor retinaculum, and it divided into the two part. One is the median part, median nerve, and another is the superficial palmar cutaneous nerve. It is the palmar actually cutaneous supply and palmar sensory supply it's from. So, and there's the tinal sign, that is the multiple time actually hitting over the nerve. Is nerve is pathological, that times it considered the numbness in this area. And the another is the upper limb neurodynamic test and carpal compression test, like the hand elevation test and the fling test. And clinically, sometime prediction rule of the winner, I will share it in the group also. Huh? What is the rule of prediction? Okay, so the diagnosis is mainly the history, then the some physical examination. You can consider the ultrasound, because if there is the swelling of the nerve, that time you actually calculate under the ultrasound. then another is the NCB, and very rarely the MRI done for this CTS. Okay, so here we can see very small uh, uniform of the median nerve, but here is the soilen. Actually is the soilen median nerve. So if we are consider between the right and left hand, we can actually measuring these things very clearly. If there is no symptoms in the left hand like that, this is the smallest one. If there is the symptoms in the right side, so it is the bigger one. So you can consider, you can just compare these two things very easily. So now, so the cross measuring the cross sectional area of the median nerve at the proximal tunnel, like the scaphoid and pisiform level, not the trapezius level. So this is the formula, like the it is the, if it is normal, consider it is normal, that is the less than the 10 millimeter square. If it is considered the CTS, that time is the more than 10 millimeter of square. It is the severe compression, that time is exactly the more than 15 millimeter of square. So how to actually measure? There is the A is the transverse diameter, and B is the AP anteroposterior diameter. Okay, now the conservative treatment, like they stop the activity actually which precipitate these things, like I am actually playing some things like this, or I am doing some things, screwing and screwing. So these types of works you should stop. Number one. Number two is the number splitting. Sometimes so you can the exercise, some exercise for the flexibility and strengthening of exercise, like the sometimes you give this NSIs if there is the very small actually like the very small area is soiling, so that time you consider the NSIs, but not improve with the conservative treatment. You can consider the either the steroid, but very important part, outside the nerve, not within the nerve. So not given any injection in here with blindly, because it may many of the time in distract the nerve, and also it causes the damage of the flexure group of the tendon, because under the median nerve there is the a lot of tendon, superficial and profundus, are just traveling under the median nerve. So never given any injection without seeing the median nerve. Then PRP and dextrose you can consider. Okay, so PRP you can just consider as the treatment of degeneration, because it causes the remyelination and the sometimes the uh, regeneration and angiogenesis and repairing this nerve. So you can consider PRP also. So dextrose, actually dextrose also it causes hypertonic solution. So it causes the inflammatory collection outside the cell around which actually cell around this nerve. So that time actually it causes the shrinkage of the tendon. Or sometimes if there is swelling of the nerve itself, that time actually it shrinks, and the inflammatory mediators and the swelling, especially the collection within the median nerve, that actually just outside the nerve. So actually it inhibit the transient receptor potential, vanillary receptor 1. So it causes the actually nociceptive sensation by the evocation of the action potential by the forming the peripheral nerve ending, and subsequently it causes or decrease the inflammation. Okay, so if we hydrodissect the nerve from the area, so we have actually considered the just give a injection under the flexure retinaculum and try to separate median nerve from the flexure retinaculum, and another injection just below the median nerve, and consider like the separation from the flexure, common flexure tendons. Okay, now the proximal intersection symptoms. So proximal intersection symptoms are very common, and it is actually uh, overuses of the tenosynovitis, and it's due to the first and second compartment. So first compartment, there is the two important tendon, and the second compartment there is also the two important tendon. So this is the first compartment. So there is the two tendon. One is the abductor pollicis longus and another is the extensor pollicis brevis. These two tendons actually goes to the thumb, and another two tendon, that is the second compartment, they are the extensor carpi radialis longus and extensor carpi radialis brevis. So these two tendons and these tendons are crossing over just around 4 to 5 centimeter proximal to the wrist joint. So if there is any direct trauma or any work that actually causes multiple or repeated actually friction this tendon, like when actually crossing this tendon, the first tendon crossing the second tendon, so that time actually there is the inflammation and there is the micro trauma and it causes the pain, but it not near the wrist joint, is just proximal near about the 4 to 5 centimeter proximal to the wrist joint or Lister tubercle. So this is the area where actually you find the maximum pain during the palpation. So here we can see the proximal intersection. So this is the APB, and under the second compartment is the second compartment, this is the first compartment. So second compartment lies the below, and first compartment lies the over the second compartment, and it crosses just few centimeter below the wrist joint. Okay. So now the distal intersection symptoms. So it is just crossing the, when actually second compartment crossing the first compartment after few centimeter distally, it also crosses the third compartment. So third compartment, which is the third compartment, there is the extensor pollicis longus. So there is the chance of another friction for just crossing this tendon. Okay, so very important thing, just for remember, one is the first letter, second and third. So when actually second is common for wall, so when second compartment tendon crossing the first compartment, that is the proximal intersection symptom, and second compartment actually crossing the third group of compartment or third compartment, so that time actually we consider as the distal intersection symptom. So you can remember with numerically, just one is the first, and second and third is the third. So second is common for the wall, both first and third. So when second is crossing the first compartment, that is considered as the proximal, and second when actually crossing the third compartment, that time actually considered as the distal intersection symptoms. So it is very nearer to the wrist joint and very nearer to the Lister tubercle. Okay. So under this tendon, that is the second compartment, there is the extensor carpi radialis brevis and extensor carpi radialis longus, and above there is the third compartment, that is the extensor pollicis longus. Okay, so clinical presentation almost the same, but only the location is the different, otherwise clinical symptom almost the same. So clinical symptoms, it is when actually flexion and extension, and that it causes the pain if there is any trauma is there. Okay, so the weightlifting, racket sports, or horseback riding or skating, that time actually it causes the over pressing or over actually multiple time repeated work, so that causes the actually pain. So it may either the swelling, tenderness, just you can when actually you tracking under the ultrasound, you can just see when actually it crossing or crossing the tendon, that area is either the any soiling or any kind of collection is there or not. So medication, so anti-inflammatory, anti-inflammatory medication like the NSAIDs, ibuprofen, sometimes the diclofenac or naproxen. If there is not improved that time, you can consider the any type of injection is steroid, or sometimes you can consider the PRP. Surgery is not so much recommended, but these are the most common cause, and also very important. But you should stop the repeated work. Actually, that causes the repeated trauma. Okay, so now the chiralgia paresthetica. So meralgia paresthetica, that is the another part. So that is in the west part, but this part is called the chiralgia paresthetica. So this is the actually affected. It's not so common, but it sometimes you may find in your OPD also. So actually it is compression, compress the superficial branch of the radial nerve. So actually where actually we have wearing a wrist and wrist. So that time actually this area actually consider for the compression this superficial nerve, and it causes the mainly the dorsal part and especially this area. Okay, and mainly it decreases the sensation because it is the sensory nerve, so only the sensation may reduce and not there is the any motor deficit, so only the sensory is. So sign symptoms, we can find out already. I have told there is the maybe the paresthesia or numbness, sometimes the tingling. All are the sensory presentation. There is no other presentation. So if it is the superficial nerve, so you can just the tunnel sign over the nerve, and another is the decrease sensation. If you are compare with the another hand, you can just decrease, there is the sensation decrease with the compare with the normal wrist. Now the another important part, that is the Guyon's canal symptoms. So Guyon's canal, it's actually mm, just the medial when the proximal flexure retinaculum uh, it's connect with the pisiforms, that time actually it's curved and down, and over there is the another ligament. So there's the very small and tiny area for two important structure. One is the ulnar nerves and another is the ulnar artery and vein. So this area, if there is any compression either by the outside, or there is any ganglia, or there is the any growth or any bony osteoarthritis, bony osteophytes, it causes the compression the ulnar nerve, and there is the some symptoms like the tingling, numbness, weakness, and troubling with the complex text like the holding the pen and writing. So these consider as the Guyon's canal symptoms. And there is the three important zone for entrapment of this ulnar nerve. There is the first important area, that is the pisiform. Second, and this area actually only the sensory diminish. If there is any problems, it is, so now here we can see uh, before the bifurcation, the main ulnar nerve is entrapped. So that time this is the zone 1. So both motor and sensory are diminished. and usually it is associated with the problem with the pisiform. Sorry, it is not hook of the hamate, it is problem with the pisiform. And the second area, zone 2 or zone 2, that is actually the only the deep motor branch of the ulnar nerve. So the mainly the motor is lost. Okay, so this is the zone. So this area is supplied by the ulnar nerve. So this area actually uh, is motor support wasting these muscles. Okay, if zone 2 is affected, zone 3 is affected, that time only the superficial and sensory branch of the ulnar nerve is only the sensory is affected. So if there is both motor and sensory is affected, so you can consider it is the proximal or zone 1. If there is only the motor, there is no sensory, so that you consider it is zone 2 area. There is only the sensory, there is no motor area is affected, so you can consider it zone 3 uh, area is affected. But zone 2 is most common, and mostly the these muscles are affected. Okay, now the ganglionic cyst, it is the collection thick jelly fluid with the single cavity, and it is just mainly the dorsal side of the um, wrist, and sometimes there is collection, and this collection is so thick and fluid, since we cannot just aspirate it with using of the 21 even 20 gauge of needle. We sometimes need to 18 gauge times. Many of the times we need the blood syringe, sorry, blood collection needle. It's there about the 16 gauge, because this collection is so thick, so you cannot actually aspirate within very tiny needle. Okay, and it is usually female are more affected, and sometimes it consider the part of the either the any wrist, not only wrist, any joint pathology like the degeneration or inflammatory type of problem. And usually this is the 20 to 40 age of age, and it may either by the direct trauma and sometimes arthritis, but many of the time we cannot actually consider there is no cause, so it is may sometimes the unknown causes. So it is soiling area. So mainly the soiling is visible when it is the flexed. Many of the time it disappear when is the just straight. Okay, and very important, there is the 50% time this ganglion is disappear. Okay, if not disappear, and with medication it is not improve and gradually increasing the size, that time actually we consider the aspiration. The wrist arthritis. So wrist is the common site, another very important and very common site for the arthritis. So there is the two type of the arthritis. One is the inflammatory arthritis and it is the degenerative arthritis. So both are actually affected this area. But in contrast of the age, in the early age, like the below 40, it's mostly in the rheumatoid arthritis or small joint arthritis. If there is the more than 40 of age, that time actually we consider as the degenerative arthritis, inspired with the all kind of the signs, symptoms, and the clinical evaluation and the uh, blood report also. So these all are considered for the evaluation of the arthritis. But if there is any soiling, if there is any like this, if there is any soiling, stiffness, redness, and joint is especially stiff during the morning or at the night time or during the resting time, so it consider or it is the window or it is the actually very good point for diagnosis of the rheumatoid arthritis. A lot of patients, they have come with this small swelling with of the wrist joint, and this pain actually increasing during the rest time and swelling. So after few months later, actually, um, when actually um, this disease is spreading over the body, so that time actually there is any other problem in the problem or any other symptoms we can find. But if you find there is the pain, swelling, redness, and pain increasing at the rest or at the night or the morning time, and this pain is suddenly just attack the person, not gradual, it's the suddenly just increasing, or is suddenly just onset, so that times actually first consider as the inflammatory arthritis, because it is very common and very common. Small joint arthritis or rheumatoid arthritis just started at the wrist. First sign you can find at only the wrist. Okay, so if your prediction like this, it's maybe the rheumatoid arthritis. So if you are just minimize the inflammation and just follow up, and sometimes in the early stage the serological study is not so well uh, positive, like the anti-CCP is not positive, like the ESR-CRP is not so high, so but not considered as the uh, it may not the rheumatoid arthritis. Just follow up. You may find out after 3 to 6 months later, because I got a lot of patients with the wrist pain, and just considering it may or may not the either rheumatoid arthritis or small joint arthritis. So just follow up and follow up after the few months, like the even after the 6 month later, I repeated doing the anti-CCP, so RA factor. So you find the positive any of the time. Okay, if the age is more, so that time actually you consider as the degenerative problem. Okay, so if in case of the rheumatoid arthritis, it is very important to early start of DMRD, because if you are not start early this kind of um, medication, it causes the damage of the joint, and it is the permanent damage, and resulting there is some deformity, z deformity, such the a lot of deformities there. So it may sometime ulnar deviation. So if you are not focusing these things as the part of the rheumatoid arthritis, so it may causes the damage, and it is the permanent damage. If you are early starting this kind of medication like the DMRD and reduce the inflammation, so you can just help to the patient, just prevent the uh, damage of the joint and other things. So if you have considered the RA, that time you also consider there is any fatigue or any weight loss or any low grade fever, weakness on. Sometimes many of the patients, I cannot take my shower because if it is the summer, temperature is so much, but I cannot take my shower because there's a low grade fever within my body. So this is the USG part, and you can just see a lot of actually collection, a lot of thickening, synovial thickening is there, and Doppler take this type of the um, Doppler started take this a lot of color within the synovial uh, thickening area. So here you can see also there is if there is a very small amount of collection, a small amount of color show under the Doppler. So it considered as the Doppler study. There is the grade 1 synovial or inflammation. So it is the grade 2 inflammation, is the grade 3 inflammation. If there is the collection is so much, so inflammation is so high, so that time you have considered it is the grade 3. So only the oral medication like the oral steroid or oral NSAIDs is not the enough for the minimize this kind of the inflammation. So that times you need um, intra-articular injection also. So regarding the Doppler study, you can also grading or you can also planning the how to treat this patient. So inflammation already we have also already sorry, it's the elbow. So medication like this medication is in case of the inflammatory medication. So that the time you can consider the NSAIDs and DMRDs and biologics, painkiller and injection also. If there is the non-inflammatory like the degenerative change, you can consider the NSAIDs, and also consider the if there is a degeneration, you can also consider the duloxetine for the treatment. If there is needed, you can also apply for the PRP. So here is the how actually you um, give your injection in plain technique. You can just crossing this tendon, and we're just crossing the synovial membrane, and you can consider your injection either. If it is inflammatory, then you can consider the steroid. If it is the degenerative, then you can consider the PRP. So thank you for patient sharing, Shirish.
Milton, thank you very much, Milton. Very nice and elaborate presentation. Okay, I'll start my. Hello, can you see my slide, Milton?
Yes, it is
Okay,
visible.
it's visual now. Is it visual full screen now?
Yes, now it is.
Okay. Good afternoon, everybody. After a very wonderful presentation of Dr. Milton, I'll be talking about some of the common hand pathology. A few of my topics has already been covered by Milton, but I'll go in very brief so that you guys won't get bored. So regarding common hand pathologies, there are lots of pain generators in the hand. So I've listed few of the pain generators in this slide. We'll be talking about pulleys and sagittal band, as well as palmar fascia, few collateral ligaments, and rheumatoid arthritis and osteoarthritis, as well as ganglia has been covered by Dr. Milton, but I'll go in a very brief in those topics, and also finally the foreign bodies in the hand. So without wasting your time, I'll be starting with first with pulleys and sagittal band. So these pulley and sagittal band are basically the fibrous extension from the palmar plate. Yeah, if palmar plate is basically a ligament which is present in the volar aspect of the palmar aspect of the hand over the metacarpopharyngeal joint, as well as in the proximal interphalangeal joint. There is a few ligaments are there. So these ligaments can be from these ligaments and fibrous arch can will appear, which will basically cover the either flexor tendon or the extension tendon and helps to stabilize it. So actually there are two types of pulleys. One is called annular pulley and another is called a cruciform pulley. So annular pulley is in the second to fifth finger. There are 5 in number, as shown in the diagram. 5 in number as shown is in the diagram, and in thumb the annular pulley are 2 in number. As if you see the lower right side of the slide, there is a picture of thumb with 2 annular pulley. And these annular pulleys arise from the palmar plate and they arches over the flexor tendon, mainly the flexor digitorum superficialis and flexor digitorum profundus, as you can see in the lower side. And these are the annular pulley, which helps to stabilize the the flexor tendon. And another pulley is also there, which is known as cruciform pulleys, which is denoted by the capital word C, capital letter C. And these are the crisscross bands which arises from the annular pulley. And these crisscross band connects these two pulleys. And then it also helps to reinforce the flexor tendon. And as shown in the picture, there are 5 annular pulley in second to fifth digit and 2 annular pulley in the thumb, because only 2 annular pulleys are in the thumb, because in the thumb middle phalanx is usually absent. So in some books they say that there are about 3 cruciform pulleys, and in some books it's written there are 4 cruciform pulleys. So these are the cruciform pulleys which helps to join the 2 annular pulleys. Coming again back to the annular pulley, our main clinical importance is in the A1 pulley, because A1 pulley is the most commonly pathological problem that we encounter in everyday life. So the mean length of A1 pulley in the adult index, middle, and ring finger is about 12 millimeters. So this is the A1 pulley. So the mean length is about 12 millimeter, and in the little finger it is about 10 millimeter. So keeping this in mind, I'll go into the another side. Okay, I'll erase this. So okay, so coming to trigger finger. So trigger finger is basically it's one of the most common hand problems that we encounter in everyday clinical practice, and actually the prevalence is quite high. In general population, it is said that about 2.6% of general population will have a lifetime prevalence of the trigger finger, and in diabetic patient, it is even more. It is about 10% in diabetic population. And the main pathology here is either increase in friction or mismatch in size between the tendon and pulley, causing irregular flexion and extension of the digit. And there can also be pain in the palmar aspect of the metacarpopharyngeal joint. As shown in this picture, you can see there is a mismatch in size between the pulley, A1 pulley, and the tendon, flexor tendon. Similar in the picture in the lower side, you can see the tendon, flexor tendon is swollen and nodular, so it cannot glide through the A1 pulley nicely. And if it glides, then the finger will be locked. So commonly patient presents with, in initial phase, they might complain with vague sense of tightness or pain over the metacarpopharyngeal joint. But in later stage, there can be a history of locking or catching of the affected fingers when the fingers is flexed. It's like trigger of the gun. Once the trigger is pulled, then it will be locked. So we can also feel a nodular thickening or swelling in the affected tendon just over the head of the metacarpopharyngeal joint. So there is one grading done by Cunell, and he has said that Cunell scale is in front of you. So he has graded the trigger finger in 5 different grading. 0 means normal movement of the finger, that we all have the normal movement of the finger, mainly the flexion of the finger. And grade 1 means there will not be locking of the finger, but there will be uneven movement of the finger. Mainly the finger affected will flex very uncomfortably and extend very uncomfortably, but there won't be any locking of the finger. So in grade 2, there will be locking of the finger, but patient can actively correct the locked finger by himself, without using any help. So in grade 3, there will be locking, but it won't be corrected actively. So he needs to passively extend the finger which is locked, and that will correct the trigger finger. But in grade 4, there will be fixed deformity of the finger. Once the finger is locked, passively it cannot be opened, or the lock cannot be opened. So these are the four gradings of the trigger finger. So regarding the ultrasound scan, normally we scan the A1 pulley with elbow extended and supinated hand. And normally we use the high frequency linear probe. Here in the slide, I have shown both axial as well as long axis as well as short axis view. In the left side of the screen, you can see the long axis view of the A1 pulley. Here, if you see very carefully, the red box is the placement of the ultrasound probe, and it is placed just over the metacarpophalangeal joint. Half of the probe is towards the head of the metacarpal and half of the probe is towards the phalanx. And between and just over the junction of metacarpophalangeal joint, you can see a beautiful hyperechoic linear fibers of flexor digitorum superficialis and profundus. And just over, if you see the there is a black thin line which is demarcated by the yellow 3 arrows. So this is the pulley, A1 pulley. And this is in the long axis view, but A1 pulley is very nicely seen in the short axis view also. If you see the right side of the slide, you can see the placement of the ultrasound probe that is just above the head of the metacarpal. And if you see here, you will be seeing the short axis view of the flexor tendon. So flexor digitorum superficialis over the flexor digitorum profundus, and just over the flexor digitorum superficialis, you can see a black anechoic line which is marked with the yellow dots. So that is the A1 pulley. So it is a ribbon-like structure which arches over the flexor digitorum tendon, and it helps to stabilize this tendon and prevents it from bowing when the finger is flexed. And if you put on a colored Doppler, we may also see these like digital arteries in either side of the pulley. And the pulley is not only the roof, the whole part, in the lateral aspect of the flexor digitorum superficialis and profundus, you can see the triangular shaped black anechoic area. This, along with the arch, upper arch, is the A1 pulley. So coming to the next slide, here are some pathological pictures that I have included. So this is the normal left upper side is the normal pulley. You can see the pulley arching over the flexor digitorum tendons, and in the lower side you can see the anechoic part has been thickened, and there is markedly enlarged anechoic triangular area. This is basically a thickening of the A1 pulley, as shown in the by the white arrow marks. If you see the right side of the slide, here also you can see there is a marked thickening of the hypoechoic, the arch which is surrounding the flexor pollicis longus. And this is the pathological pulley. And normally, if this is seen in the ultrasound, then there might be a trigger finger in the patient. So normally in the trigger finger, what we do is we can inject local anesthetic as well as steroid inside the tendon or just above and below the tendon in those patients with a trigger finger. So it can be injected both in long axis view as well as in short axis view. In the long axis view, normally we inject the steroid and local just above and below the pulley. But in short axis view, if as shown in this picture, we can inject the local and steroids inside the pulley as shown in this white triangle. And you can see the trajectory of the needle that is indicated by this red dotted line. So this is the trajectory of the needle, and the final needle position will be at the triangle, inside the triangle in the lateral aspect of the flexor digitorum superficialis and profundus. We can inject on either side of this triangle, that is either in the ulnar side or in the radial side, can be injected for the treatment of trigger finger. So coming to the next problem in the pulley, that is also called rock climber's finger. So in this, basically what happens is there is a rupture of this A1, not only A1, but generally annular and cruciform pulleys. So damage in the annular and cruciform pulley can be due to the repeated microtrauma or it can be because of the acute trauma, which is commonly seen in rock climbers' finger, especially middle fingers and ring finger is usually affected. And it usually happens when the finger is forcefully extended against the resistance. And you can see the picture of the rupture of the pulley. You can see in the left upper side of the picture, you can see rupture of A2 pulley as well as cruciform pulley and A3 pulley. If this pulley is ruptured, then the integrity of the this flexor tendon is lost. So there will be bowstringing of the tendon or bowing of the tendon when the finger is flexed. And in ultrasound picture, if you see the short axis view, which is in the lower side of the slide, you can see the distance between the bone, mainly the phalanx or a metacarpal, and the tendon will increase. And in between the tendon and the bone, there will be an echoic shadow. That is basically a hematoma or effusion. So this is a classical picture of the rock climber's finger if the pulley has been ruptured. So this is the left side is the short axis view, and in the right side, you can see the long axis view of the pulley. And you can appreciate the distance between the flexor tendon and the proximal phalanx has increased. And this flexor digitorum tendon is no more in close proximity with the phalanx, that the distance has been widened, and you can see the anechoic fluid in between the tendon and the proximal phalanx. So this is a classical picture of the rock climber's fracture, which usually happens if the if the annular as well as cruciform pulleys are ruptured due to the acute trauma. So another problem that is encountered in the pulley is the ganglia, as Dr. Milton has said. The ganglia can also occur over the pulley. So this is the picture of the ganglia over the A1 pulley. You can see the bone in the lowermost part. This is the flexor digitorum tendon, and above this is the pulley. So just above the pulley, you can see an anechoic rounded structure, which is the ganglia in the pulley of A1 pulley. So another common problem which is encountered in the pulley, mainly the dorsal pulley, is sagittal band rupture. So this sagittal band is located in the dorsal aspect of the hand, and these sagittal band also arises from the palmar plate, and it arches over the extensor tendon of the hand, which helps to stabilize the extensor tendon. So as you can see in the picture, these are the sagittal band, and if you see the ultrasound picture, you can see the extensor tendon lying over the metacarpal head, and at the lateral aspect you can see the anechoic extension in the both sides as shown with the arrow. So these are the sagittal band, which helps to stabilize the extensor tendon. And this trauma or rupture of sagittal band is very much common. So it usually occurs secondary to the micro trauma or the trauma usually seen in the boxers and fighters. Okay, when they box, due to the repeated trauma, the sagittal band can be ruptured, and there can be dislocation of this extensor tendon, which I'll be showing in the next slide. So normally this extensor tendon will be dislocated to the contralateral side of the rupture of the band. So you can see in this picture, this is the dynamic ultrasound picture of the rupture of sagittal band where the extensor tendon has been dislocated. So in the picture A, you can see the extensor tendon lying very nicely just above the metacarpal head, and this anechoic line at either side of the tendon are the sagittal band. And this picture is taken when the finger is extended, but when the patient flexes the fist or flexes the finger, you can see the extensor tendon is no more just above the metacarpal head. It has dislocated in the lateral side, and this dislocation is usually occurs in the opposite side of the rupture of the sagittal band. So in the picture B, since the tendon is in the left side, the right side of the sagittal band is ruptured. As also in picture C, you can see the tendon is in the lateral side of the metacarpal head, and it is not over the head of the metacarpal. That means the pulley, sagittal pulley has been ruptured and the extensor tendon is dislocated to the lateral side. So this is usually, when we see these patients, we usually send this patient for the orthopedic referral for the repair of the pulleys. So coming to palmar fascia. So as we all know, this palmar fascia is basically a direct communication of the flexor retinaculum and palmaris longus tendon over the palmar aspect of the hand, and it covers the flexor tendon as well as the neurovascular structure of the palmar aspect of the hand. It consists of longitudinal superficial fibers as well as deep transverse fibers, and distally these palmar fascia splits into 4 different bands, and these bands are attached to the proximal phalanx. And this palmar fascia, which is a thick fascia, is connected to the deeper structure by the means of 9 various fibrous septas. And there are 2 marginal septas, and in between these 2 marginal septas, there are another 7 intermediate septas which connect the palmar fascia to the deeper structure. Okay, so one of the most commonly encountered problem in the palmar fascia is Dupuytren disease or Dupuytren contracture, and it is basically characterized by the nodular thickening and variable degree of retraction of the palmar fascia. As you can see the picture in the right side, there is a nodular thickening of at the palmar aspect of the hand, and this there is a retraction of the little finger as well as the ring finger. The patient cannot fully extend these 2 fingers. So this is a commonly, we can see these patients commonly in the pain clinic. Normally the patient profile is above 50, and this Dupuytren disease or contracture is very much common in the manual worker, those who do manual activities. In these patients, the Dupuytren contracture is very much common, and in male it is very much common. The ratio between male and female is 7.6:1, and it has a strong genetic predisposition also. So it can be transmitted as autosomal dominant. And patient usually presents with painless nodule and contracture as well as limited mobility of the finger. So finger will be flexed and it cannot be extended. So in ultrasound picture, this is the ultrasound picture of the Dupuytren contracture in the short axis as well as in long axis. The upper side of the picture, you can see the hypoechoic structure over the this extender tendon. So this hypoechoic nodules between the subcutaneous tissue and the flexor tendon is a Dupuytren nodule. Similar, this is the short axis view. In the right side, you can see the long axis view where you can see the Dupuytren nodule lying over the flexor digitorum superficialis and profundus. So this is the example ultrasound picture of the Dupuytren contracture. In the lower side of the picture, you can see the nodule and echoic nodule just over the flexor tendon, and this is extending downwards to the deeper structure. So this is a classical picture of the Dupuytren contracture. Here also, if you see the Dupuytren contracture, pain associated with it, we usually refer to the orthopedician, our colleague orthopedician, to release of the Dupuytren contracture. Now coming to the collateral ligament of the hand, which is most commonly affected, and many patients will come with this ulnar collateral ligament injury. So normally the metacarpophalangeal joint as well as interphalangeal joint, these are the condyloid type of joint, and these joints are reinforced by radial and ulnar collateral ligament. If you see the picture in the right side, these are the interphalangeal joint, and this is the metacarpophalangeal joint. And you can see in the radial aspect, there is one ligament, which is called radial collateral ligament. And in the ulnar side, there is another ligament, which is ulnar collateral ligament. These collateral ligaments helps to stabilize the interphalangeal as well as metacarpophalangeal joint. And we are more interested in ulnar collateral ligament of the thumb, because the function of thumb of 50% of the function of hand is by the function of the thumb, and it plays key role in grabbing, grasping, writing. Many activities are associated with are associated with the integrity of this metacarpopharyngeal joint of the thumb. And if there is a rupture of this ulnar collateral ligament, there will be a valgus opening of the joint, and the metacarpopharyngeal joint will not be stable. So normally the ulnar collateral ligament of the metacarpopharyngeal joint of the thumb is usually 12 to 14 millimeter in length, and it is about 4 to 8 millimeter in thickness. And it basically originates from the dorsal aspect of the first metacarpal head. It runs towards the palmar aspect, and it is attached to the tubercle of the palmar, proximal phalanx. So, and some of the pathologies which are more commonly associated with this ligament is rupture or sprain of this ulnar collateral ligament. The two commonest pathology that we encounter is skier's thumb, which occurs usually when there is acute traumatic radial hyperabduction of the thumb. Like in the skiers, there can be forceful hyperabduction of this causing sprain or partial tear or even full thickness tear of the ulnar collateral ligament. So this is called skier's thumb. And there is another pathology which is also associated with this ulnar collateral ligament, that is called gamekeeper's thumb. The gamekeeper thumb, there is usually a chronic condition where the ligament of this ulnar collateral ligament is lax and is non-function, but there is no tear or sprain or anything like that in the ulnar collateral ligament. And there can be sometimes the damage of the ligament can be associated with avulsion fracture, as shown in the picture in the lower side. You can see there is an avulsion fracture of the proximal phalanx because of the rupture of the ulnar collateral ligament at its attachment, or there can also be a joint effusion. So this is the ultrasound picture of this ulnar collateral ligament skier's thumb. You can see in the upper picture, this is the distal part of the metacarpal head, and this is the phalanx. So there you can see an anechoic arch connecting the metacarpal head and the phalanx, and you can see there is a thickening of this ulnar collateral ligament, as well as the loss of continuity of the ulnar collateral ligament at its attachment to the proximal phalanx. So this is basically a acute partial thickness tear of ulnar collateral ligament, and this is also one of the example of skier's thumb. Another, in the lower part of the picture, you can see the ulnar collateral ligament is retracted because of the full thickness tear at the middle. So there are two stumps. You can easily see two stumps, and in between the two stumps of the ulnar collateral ligament, you can see the hypoechoic or anechoic area, that is the tear or effusion, full thickness tear or effusion of the ulnar collateral ligament. And this picture you have already seen, there is a tear as well as avulsion fracture of the ulnar collateral ligament. So these pictures are the example of the skier's thumb. So coming to the another most common problem that we encounter in everyday practice, that is rheumatoid arthritis. As we all know, this rheumatoid arthritis is a chronic systemic inflammatory disease involving the synovial membrane of the joints, and it is very much common in female, and normally 0.5 to 1% of world population is affected with rheumatoid arthritis. Actually, we don't know the cause. The cause can be multifactorial, and here also it has a very strong genetic predisposition, and it's also an autoimmune disease. Normally at the level of wrist and hand, there can be various manifestation of the rheumatoid arthritis. It can affect joints, it can affect bone, tendon, as well as subcutaneous tissue and skin. In the wrist as well as in metacarpal, in the hand, rheumatoid arthritis mainly affects wrist, metacarpopharyngeal joint, and the proximal interphalangeal joints are more affected. And if you see in the joint, there can be joint effusion, there can be hyperemia in the joint, or features of synovitis, or joint space narrowing can be easily seen. Similarly, in the bone, there can be osteopenia, periarticular osteoporosis can also happen, subchondral cyst can be visualized in X-ray. There can be also erosion and edema in the X-ray picture. Similarly, in the tendon, there can be tenosynovitis, enthesis. There can also be full or partial thickness tear, especially involving the flexor carpi ulnaris and flexor carpi radialis, as well as extensor carpi radialis and ulnaris. So these four tendons are most commonly affected in the hand. So coming to the ultrasound picture, in the left side of the ultrasound picture, you can see the effusion in the distal radio-ulnar joint. This black anechoic fluid is the effusion, which is more commonly seen in patients with rheumatoid arthritis. And in addition to this, you can also see the features of tenosynovitis. So black anechoic structure surrounding the ulnar, this ligaments in the either side of the joint. So these are the pictures of the rheumatoid arthritis in the ultrasound. Similarly, in the right side of the picture, you can see the effusion around the extensor carpi ulnaris. So this is the tenosynovitis of the extensor carpi ulnaris seen in the rheumatoid arthritis. Here in the picture B, you can see the synovial thickening of the synovial membrane, which is known as synovitis of the extensor carpi ulnaris. And if you turn on the color Doppler, you can see lightening of the color Doppler, which basically shows there is hypervascularization due to the rheumatoid arthritis. And if you see very nicely, you can see the erosion in the ulnar, in the distal part of the ulnar, as in picture C and D, you can see that there is smoothness of the ulnar bone is lost. So you can also appreciate the erosion in the ulnar, which is commonly seen in advanced rheumatoid arthritis ultrasound picture. So this is another example of the rheumatoid arthritis. This is the recesses and the palmar recess of the hand. You can see the radius, scaphoid, and trapezium. This is the long axis view. You can see in the recess of the radioscaphoid recess, you can see the synovial thickening and few effusion in the joint. So this is a typical picture of the rheumatoid arthritis patient with rheumatoid arthritis. And if you turn on the color Doppler, you can also see hypervascularization in the radiocarpal joint. So this is also a common picture of the rheumatoid arthritis patient ultrasound picture. So in the right side of the ultrasound picture, you can see this is the sonogram picture of the dorsal compartment, fourth dorsal compartment. So in the fourth dorsal compartment, as Sir has said, that there are 5 tendons, but here you can see only 3 tendons are there, and there is marked fluid inside the fourth compartment. This basically shows that there is a rupture in the extensor tendon, and as well as tenosynovitis, which is also a common feature of the rheumatoid arthritis. And below this fourth compartment, you can see the synovial thickening, which is a very characteristic feature of the rheumatoid arthritis ultrasound picture. So another common problem that we encounter in hand is osteoarthritis. So osteoarthritis is very much common in hand, and major site of osteoarthritis in hand is first carpo-metacarpal joint, that is trapezio-metacarpal joint, as well as distal interphalangeal joint. So these joints are most commonly involved, as you can see in this picture. So this is the upper right side of the picture. You can see red osteoarthritic bone of the first carpo-metacarpal joint. And in the osteoarthritis, typically we see narrowing of the joint, we can see cartilage erosion, we can see subchondral bone sclerosis, osteophyte formation, as well as synovial hypertrophy and joint effusion. So most of the picture can be seen in the plain X-ray as shown in the picture. So if you see the plain X-ray, you can see the narrowing of the joint space, cartilage erosion, subchondral bone formation, mainly in this distal interphalangeal joints, as well as osteophyte formation. But the advantage of the ultrasound is that we can detect synovial hypertrophy as well as joint effusion by the help of ultrasound. So this is the ultrasound picture where you can see the synovial hypertrophy in between the distal in the distal interphalangeal joint. In addition to this, you can also see erosion of the distal phalanx, which is an osteophytes in the distal phalanx, which is a typical or classical presentation of the patient with osteoarthritis. So coming to the another common area, that is carpometacarpal joint or trapeziometacarpal joint. So here you can see this is the osteoarthritic picture of the patient, and the patient usually complain of pain in the distal aspect of the wrist at the base of the thumb. Especially patient profile is elderly patient. This is very much common in the elderly population. And this is the in the right side of the screen, you can see the ultrasound picture of the carpometacarpal joint. And as you can see in the picture, the placement of the ultrasound probe is in the long axis with the metacarpal bone of the first digit, and just below you can see the trapeziometacarpal joint. And in the lower side of the picture, you can see the injection, either PRP or steroid, given at the carpometacarpal joint. This is the white dot just below the red line is the site of injection, and this injection is done in the short axis view in the carpometacarpal joint. In the long axis view, injection is very much difficult because angulation of needle will be very hard. So normally we prefer short axis view, out of plane injection in the carpometacarpal joint. So Dr. Milton has already covered this ganglia, but I'll summarize in very brief. So ganglia are the space occupying lesion and most frequently encountered in the hands and wrist. And this is also very much common in female, and normally between third to fourth decade of life. This is very much common in the female population, and it consists of gelatinous material which is encapsulated by the fibrous capsule, and they can arise from articular capsule or synovial sheath, or even in pulli, as I've shown in the previous slide, or from the retinaculum. And it usually presents as a small to moderate size from or nodular shaped structure, which is poorly compressible. And in the ganglia are not commonly painful, but if it is inside the osteofibrous canal like Guyon's canal or carpal tunnel, then it can cause compressive neuropathy. And in ultrasound, it usually appears as a well-defined nodule with an anechoic cyst-like mass, which usually resists the compression. So these are the various ultrasound pictures of the ganglia at various places. So in the upper left side of the picture, you can see the ganglia at the radiocarpal joint. So this is the distal end of the radius, and this is the carpal. And just above the radiocarpal joint, you can see a well-defined anechoic round structure. So this is the ganglia at the level of the wrist. And in the lower left side, you can see the ganglia over the A2 pulley. So this is the proximal phalanx. Over the proximal phalanx is the flexor digitorum tendon, and over it is the pulley. So just over the pulley, you can see a nodular, well-defined anechoic round structure. So that is the ganglia of the pulley. And in the right side of the slide, you can see the ganglia arising from the retinaculum of the dorsal compartment, that is first dorsal compartment. And this is the ultrasound picture. You can see the white arrow is the retinaculum, and from the retinaculum is the ganglia is arising. In the lower part of the right side of the slide, you can see a ganglia, but it is in the carpal tunnel. So when the ganglia is inside the carpal tunnel, it can cause pressure in the median nerve and cause syndrome. in patient with foreign body are very much common in pain cleaning, and these foreign bodies such as glass, metal, or wooden splinters, or even thumb is frequently encountered, and they find their way into the palm or soft tissue during work or play. So these are the typical ultrasound pictures of the glass or metal or the wood as shown in the table. So all of these foreign bodies are hyperechoic in ultrasound picture, but metal is the most hyperechoic object. If the foreign body is the glass, we can see hyperechoic object with posterior reverberation artifact, which I'll be showing you in the slide. Or if it's metal, then the metal will be highly hyperechoic, and there can be either acoustic shadow like we see in the bone, or there can be reverberation, which I'll be showing in the slide. And if the foreign body is wood or other thorn inside the hand, then it is also hyperechoic, but there will be no reverberation, or there will be no acoustic shadow formed by the wood or the thorn. So this is the picture of the various foreign body. In the left side, you can see as shown by the arrow, white arrow. This is the picture of the ultrasound picture of the glass fragment, and below this glass fragment, you can see the reverberation, which is an artifact. This line, white line, is a glass, and just below it, everything is the reverberation artifact. This is the glass as a foreign body. And if you see the right side of the slide, there is an X-ray picture also shown, as well as ultrasound picture also shown side by side. In the X-ray, you can see highly hyperechoic structure at the near the head of the metacarpal bone. And if you see in the right side, you can see a highly hyperechoic line with a reverberation just below this hyperechoic line. And this is the metal foreign body, which is seen in the ultrasound picture. And if you turn on the color Doppler, you can see the lightening of the color Doppler if there is any infection or granuloma, which usually surrounds this foreign body. So if you see, this is the example of the foreign body wood. Here you can see there is no posterior acoustic enhancement or no posterior acoustic reverberation. So this is the classical picture of the foreign body, mainly the wood or any thorn or any particulate substance of the wood, plant-based particulate substance. So this is the classical picture of the ultrasound picture if there is wood as a foreign body. Okay, so you can also see the granuloma surrounding the foreign body as a hypoechoic structure around the foreign body. Thank you. So thank you very much. So this is the very short few clinical pictures that we encountered in ultrasound in a daily practice. So any questions? Hello? Is anybody there? Hello? Milton, are you there? So today, Dr. Gautam Das has left because of some important work. I'll be there to answer if there is any queries or any thing that you want to elaborate. I'll be gladly answering your questions. And no questions, my friends, students. Hello, Milton, are you there?
Thank you, Shirish. Thank you, Shirish, for your nice presentation.
It was very short because of you have covered.
No.
So Sir has told us to answer any questions. So if there is any question, me and Milton will be very glad to answer. Okay, so no question for now. So have a nice time, go through the slide, and if there is any question, Sir is there to answer as well as us. So we'll be seeing you next Thursday for another module. Thank you very much. I'll be stopping this year, okay?
Okay, thank you.
Okay, Milton, have a nice time.
Okay, thank you.
See you.
Okay, Shirish.